Thank you again. So the purpose of this lecture is to address the difficulties we face daily in diagnosing and treating cracked teeth. My aim is to help you reach a quicker and more efficient diagnosis of cracks, and most importantly, to assist in making the right treatment decision, whether to try and finish with just a restoration or a crown, perform a root canal treatment, or even consider extraction. I will briefly describe the next slide. What you see in the slides as they demonstrate the challenges in diagnosing very well. On the top left, you can see a surgical exploration of a lower mandibular first molar, which ended with diagnosing a vertical root fracture on the mesial aspect of the distal root of the molar, and eventually extraction. Below it, there's a coronal crack penetrating one of the canals discovered during a root canal treatment. In the two middle images, there's an X-ray image of a tooth that was referred to me. They referred the second premolar for root canal treatment because of a periapical radiolucency, and eventually all of the presenting radiolucency was the cause of a vertical root fracture in the mesial root of the first molar, and extracting the first molar solved all of the problems. The two right slides I'll describe later, and not now. So actually, the idea for the presentation started with not in recent years, but when my wife and I purchased our first apartment, we went to the lawyer's office to sign the contract, and then he started like talking and asking, "What do you do for a living?" I said, "I'm a dentist." And I said, "Ah, nice, I sued my dentist." And then I asked him, if we're already at it, why did you sue your dentist? So he told me that a pain that wasn't diagnosed, and he went to the dentist and he told her, "I have a pain." She did an X-ray. She didn't see anything. She clinically diagnosed. She didn't see a crack. She didn't see any caries, anything. And eventually she referred him to an oral medicine specialist with a question whether it's a trigeminal neuralgia. And he said he went to his family physician to try to go to here in Israel, you go to the physician first, and then you change the referral to the referral that is suitable for the Kupat Cholim, for the insurance. And the family physician saw the referral. She said, "Why? You don't have to go to the oral medicine specialist. I can treat you. I know how to treat that trigeminal neuralgia. I'll treat you myself." And he started taking medications, Tegretol. And after a few months, the tooth that was cracked broke, and the pain stopped. And he sued his family physician and the dentist. So in recent years, actually, I heard the same story today in the morning from a different patient with Tegretol and everything, strangely. So in recent years, I assume most of you have noticed that we're seeing much more patients with cracked teeth. And we believe it's due to periods of stress during the COVID-19 pandemic. We noticed the extreme increase in cracks that were diagnosed. And it wasn't just a feeling. The ADA conducts periodic surveys among the members of the ADA, and it was indeed found that there are reports of more diagnosis of bruxism, more temporomandibular disorders, and more cracks compared to the pre-pandemic period. So in fact, we had several kinds of dental epidemics within the pandemic. And later, published studies provided scientific validity to the findings of the surveys, and it was found that in years 2020 and 2021, there was a significant increase in the diagnosis of cracks of patients. In other words, it's clear to us today more than ever that psychological stress influences the formation of cracks through the pathways of the temporomandibular disorders. And actually, you don't see it in the States, but in Israel, since October, since the war started, we're seeing an insane number of cracked teeth. So the lecture will be divided into 3 topics: the types of fractures and cracks, diagnosing options and methods, and then treatment options. And I'll focus on cracks, but I'll briefly mention also the vertical root fractures, the VRFs, as they are as important as cracks. There are 5 categories of longitudinal fractures and cracks designed to allow us to better communicate. There's a lot of confusion between the terms, both in our daily clinical language and sometimes also in professional literature. The confusion is mainly between crack and fracture, with a tendency being to refer all fractures and cracks together with the word crack. So let's start with craze lines, which are cracks limited only to the enamel and do not require treatment unless it's purely aesthetic. We see a lot of cracks of these craze lines, mainly in anterior teeth, but we must remember that they appear to the same extent also in premolars and molars, and sometimes also seen on marginal ridges, which may mislead us into thinking that there is a crack extending into the dentin of the tooth when in fact there is no crack, it's a craze line. And this is an important and interesting article by very famous researchers in endodontics who did histology on various types of cracks. At the top, we see a molar with many craze lines on the mesial or distal aspect. In the histology section, in slide D especially, you see that none of them except one reaches into the dentin, and the one that reaches into the dentin reaches very slightly into the dentin. There were bacteria in one of the cracks, which of course explains the staining that occasionally occurs in this crack. Our problem in diagnosis begins when there are only mild symptoms from the area, because the craze line might mislead us, as I said earlier, into thinking that the tooth is cracked. In such a case, if we indeed suspect that the tooth was cracked, the only way for us to make sure that it is not a crack but a craze line is to drill through it and see whether the crack extends into the dentin. If we are not convinced that the tooth has pulpitis or necrotic, and we drill through it and we don't see a crack extending into the dentin, then this is the time to stop and rethink. For all the fractures and cracks next in line after craze lines, the main question is for diagnosis is whether the fracture or crack started from the crown of the tooth or from the root of the tooth. Cusp fractures, cracks, and split teeth start from the coronal surface, progress apically, and affect the enamel dentin, and may eventually affect the pulp as well as they extend apically. And so on the top, you see cusp fractures, which can be complete or partial. The main question with them is restorative, whether they can be restored or not. Sometimes a root canal treatment is needed for attention, but if there is enough tooth structure, of course, it is better to avoid the root canal treatment in these cases. At the bottom, we see a cracked tooth, which is defined as a partial, not complete fracture, a crack, that begins in the crown and progresses apically. Most often, the direction of the cracks is mesiodistal, but sometimes we also see surprises in other directions. These cracks are more centralized compared to cusp fractures, so there is a higher chance that they will involve the pulp eventually. We will distinguish between a crack and a cusp fracture or split tooth by the fact that between the parts of the crack, there is no mobility, as opposed to the existence of mobility when it comes to a cusp fracture or a split tooth. And as I said, I will elaborate later on the diagnosis of a cracked tooth and treatment approach. And this, of course, is the split tooth, which is already a complete fracture from the crown towards the apex. And it is also usually mesiodistal, as it's the progression of the crack apically. The treatment here is usually extraction because the root is already involved and split. And VRF, vertical root fractures, start exactly the opposite way in the root and progress towards the crowns. They appear almost exclusively in teeth that have undergone root canal treatment. The starting point can be at the apex, but not always. It can also be at another point on the root canal surface. For example, a common starting point that is not the top, the root tip, is the end or opposite the end of the post. And when we see the cortical lesion from the end of the post to the marginal bone, then we also suspect a vertical root fracture. Usually, we see them at the stage where they are easy to diagnose, when there is already a narrow and deep pocket that is very characteristic of them. But sometimes when the fractures haven't progressed enough to the cervical area, and there's still a cervical bone color, it prevents us from diagnosing a pocket because it doesn't exist yet, and it might confuse us, and we won't be able to know that it's a vertical root fracture until the pocket appears. In the video, you see what was planned as an apicoectomy, and unfortunately, immediately upon flap elevation and removal of the granulation tissue, it was clear that the tooth was broken. There was a vertical root fracture, and eventually it went for extraction. Additional clinical and radiographic features that are very characteristic of VRFs is the presence of a sinus tract that is often located cervically and not apically, which at first glance will make us suspect the presence of a VRF, these sinus tracts that are cervically located. And the radiographic feature, the classical radiographic feature of a vertical root fracture is a J or U-shaped lesion that wraps around the root, but also lateral lesions, all of which will make us suspect the presence of a VRF. On the other hand, about 20% of the VRFs do not present a lateral lesion, but an apical lesion, a sole isolated apical lesion without a lateral part of the lesion. and hence the difficulty in diagnosing them in these early stages. So I will focus on the cracked tooth because there are the main teeth that for which questions arise, both in terms of diagnosis, treatment methods, and long-term prognosis. In the video running in the background, you see a tooth that has already been treated before, and when I came to retreat it, I saw a crack, a coronal crack. The crack does not extend much beyond the occlusal part of the crown. Although at first glance it is suspected of continuing apically. So much for the types. Now we'll talk about the diagnostic challenge of the cracks. So I focused on cracked teeth and less on the other types because at least for me, the diagnostic, therapeutic, and also legal dilemma is the greatest with these teeth, the cracked ones. In terms of a diagnostic dilemma, a relatively recent study that examined the approaches to treatment and reasons for referral to endodontists in cracked teeth found that the most common reason for referring a cracked tooth to an endodontist is uncertainty about the diagnosis of the crack. And that's what we're trying to solve now. So let's start with the symptoms. The symptoms of cracks are highly variable and confusing. We have the entire spectrum of symptoms in dentistry. The most common recurring story is that of a patient who has been to their dentist, sometimes even 2 to 3 dentists, with a complaint that they sometimes have pain when chewing or with cold or hot. The dentist examined, took x-rays, said he or she didn't see anything that is wrong with the tooth. Everything looks fine, but the patient has pain. Sometimes something is bothering the patient, so they seek out and turn to another dentist and another dentist until finally someone suspects a crack in the tooth. This happens a lot when the symptoms are very mild, and the inability to diagnose a crack when it is only in early stages is very common. When there is already pulpitis, a periapical lesion, or even a cracked amalgam restoration, mesiodistal, without too many symptoms, suggesting a crack underneath, it is much easier to diagnose these teeth. The classical article on the topic is the cracked tooth syndrome of Cameron from 1964. It's an incorrect name because it's not a syndrome. He described a condition of unexplained pain that was revealed to be a crack, and he found that teeth cracked more in mandibular second molars, with shallow amalgam restorations in women more than men, and vital teeth and not necrotic. So the diagnosis of a crack is difficult when it is not visible to the naked eye. We, of course, rely on the entire regular and fixed examination sequence that every patient who comes to us goes through. But there are several tests, both regular and additional, that I would like to emphasize and detail. So here is a list of all of the tests that are done for patients who come for an examination, and of course the patient's complaint and history and regular subjective examination. But here there is a special emphasis on the visual examination. A crack in the tooth will usually be in the mesiodistal direction, as I mentioned. Sometimes if there is a restoration that is not cracked, we will see the continuity of the crack on the marginal ridge. And this is my first emphasis that I already mentioned, because a crack on the marginal ridge is a very common finding and does not mean that there is a crack underneath that extends into dentin, just like we saw with the histology of the Kray's lines. Therefore, a crack on the marginal ridge itself does not constitute an indication for any treatment. So the clinical observation will often not lead to a simple diagnosis of a crack, and we will usually need aids such as percussion testing, bite tests, cold tests, etc. In the picture, without the patient's symptoms, which had pulpitis and the crack on the it's a composite restoration, and the crack on the restoration, I wouldn't know whether this line on the marginal ridge is a crack or a Kray's line. The next test that I will emphasize, and it is one of the most important in the diagnosis of all cracks and fractures, is probing, is periodontal probing. And this is a very important test before any root canal treatment, because there are often surprises, and there are usually for the worse and not good surprises. So it is good to know about them before the treatment and not in retrospect. I like to probe with a plastic periodontal probe, and I do this in every case that comes to me, not just in cases where I suspect fractures or cracks. A plastic probe is more flexible than a metal probe, and then therefore it is easier to flow with it into the crack, into the pocket, the narrow pocket, especially when it comes with to crowned roots, teeth, because often the emergence profile of the crown doesn't match the emergence profile of the tooth, and there's an angle between them, and a metal probe will be much harder to flow into a pocket with these differences in angles. When there is a localized pocket greater than 5 millimeters, this is the point at which we need to suspect the presence of a crack, or in the case of my video, a fracture, a VRF. This is important point here that I want to remember: a localized pocket over 5 millimeters. Even in a case where there is already a crack in the tooth, a pocket that is over 5 millimeters in depth is a negative prognostic factor. In other words, the presence of a pocket over 5 millimeters reduces the survival rate of the cracked teeth. The next technique that I would like to speak about is transillumination, that may assist in diagnosis because the crack line breaks the light, thus making it easy to diagnose the presence of a crack in the tooth. However, it is an uncommon test because it is almost impossible to obtain it was hard to obtain the dedicated equipment with a strong light source for transilluminations. And today, it's easier because we have, I think that I even saw on Amazon that these LED lights are being sold for transillumination in dentistry. Here in Israel, we don't have much of them, unfortunately. But in the States, it's very easy to get your hands on one of these lamps and try to transilluminate and see whether the crack breaks the light through it, and then you might suspect that there is a crack on the tooth. Another important test is the bite test. The most important device in the bite test is the tooth sleuth. Here's a video of a patient who complained of sensitivity to chewing after restoration, with a sensitivity localized only to the palatal cusps, and the sensitivity tests were normal. My possible diagnosis are either a fracture of a cusp, or a palatal wall, a whole palatal wall, a lingual wall, or sensitivity as a result of shrinkage of a composite restoration that is in the tooth. And when you do the bite test, what you expect to see is that the patient will have sensitivity not when biting, but when opening the teeth. That's a very classic result of the test. And here is an interesting article from the Quintessence, which compared the test using biting on a wet cotton roll, pellet, not pellet, roll, versus tooth to identify the cracked teeth, and to try to locate a crack. When there is a crack, only 32% of patients have pain when biting on a cotton roll, compared to 91% when tested with a tooth sleuth. So a tooth sleuth is a recommended device for every dental clinic that wants to try to find some cracks. And the very important point is the radiographic examination. As I already mentioned, and we saw, there are common radiographic criteria for deciding the suspicion of the presence of a crack or root fracture. And I already showed several periapical radiographs that should have raised a very reasonable suspicion of these of their existence. But we have another powerful tool to our disposal, and that is the CBCT, the CAT scan. And I say a powerful tool not only because it's powerful in diagnosis, but also because it is powerful in ionizing radiation. Less powerful than in the past, true, but certainly more than periapical X-rays that are in the office that we take usually. There is a tendency to use this tool more and more for diagnosis, and it's great, and it's a great tool for diagnosis. But we need to make sure that we are not abusing this tool and exposing our patients to unnecessary radiations. I brought here several articles, and there are more on the topic, all showing that it is very difficult to almost impossible to see the crack itself or the root fracture itself on a CBCT scan, because they are usually too small. The size of a fracture or a crack is smaller than the smallest voxel size I know of today in clinical use. What can confuse us is the diffraction of the X-rays, or more correctly, beam hardening, where there is a radio-opaque material inside the canal, like a root canal sealing material. It causes diffraction of the X-rays around the area, which especially appear in interfaces and interfere with the reading of the CBCT. We see this especially in crowns with large metal restorations, but a root canal filling can also cause the diffraction, and many times this can confuse us into thinking that this black line on the distal root of the tooth is a fracture that we see when it's a beam hardening, and the fracture is probably, if exists, it's on the mesial root of the tooth, because I see the radiolucency which is more adjacent to the mesial root. But this image of the CBCT does indicate a root fracture because of the shape of the lucency, which is J-shaped and which is very classical for a root canal, for a vertical root fracture. And another case that was on the first slide, this is an old CBCT scan of a tooth with a root canal treatment, a nice root canal treatment in a premolar, upper premolar with 3 canals. And we see on the periapical, the regular periapical, we see only a apical radiolucency. And when we're scanning the CBCT image, we can see a palatal radiolucency, which indicates a vertical root fracture also. So what about CBCT and cracks? I want to mention another article from 2022, Adam Azim, which when he was in Buffalo, now he moved to the University of the Pacific. They published an article and compared periapical radiographs versus CBCT scans for detecting cracks and fractures. And he found that CBCT is more sensitive in finding vertical bone defects. And in vertical root fractures, there was a loss of the cortical plate, which was also better observed on the CBCT compared with the periapical radiograph. He found that when there are cracks, the intact cortical plate interferes with their diagnosis on CBCT. So there's no reason to send a tooth that is suspected as having a crack to a CBCT scan. Bacteria are also present inside the cracks and fractures, entering the tubules, and they are the ones that cause the inflammation, the inflammatory response in the bone, and the formation of pocket opposite that crack or fracture, and also the inflammatory response in the pulp and symptoms. And this is the same article from before that did histology on many cracked teeth and that were extracted, and they show exactly as in caries, penetration of bacteria through the crack to the pulp, and penetration of bacteria along the fracture lines, also in the depth of the dentinal tubules. So up until now, we talked about what we do see on X-rays or CBCT scans when there is a crack or fracture, and when in fact what's important is what we don't see radiographically when there is a crack. And this brings me to the most common story about a patient comes with a new crack. The patient arrives complaining of pain when chewing, cold, sometimes even severe pain, sometimes even pulp necrosis already, and we take an X-ray and we don't see anything, nothing. A tiny restoration, everything looks normal. It's very far from the pulp. There is no seen or observed etiology that would explain the symptoms of the patient. And that's exactly the point. If there are clear and focused symptoms and there is no etiology, then the etiology that should arise in our suspicion is a crack. I like to see an etiology. If that same patient with the symptoms had a large carious lesion on the X-ray, then our lives would be much easier, but they're not sometimes. And another important test that is important for me to mention, and it is actually not done routinely, but as an option, when we still suspect that there are symptoms as a result of trigeminal neuralgia and not from a crack, is the selective anesthesia. We anesthetize by infiltration from mesial to distal, from the midline posteriorly. Intraligamentary anesthesia can be performed if we want to be even more precise when anesthetizing a single tooth. First of all, this is a test that will allow us to focus on the one tooth that hurts when it's not very focused. But what's important is that if we anesthetize all of the teeth and the pain continues, then the suspicion of trigeminal neuralgia is greatly strengthened. The last test, and it's a test in quotes, and it's not really a test that I would like to mention, is the removal of the restoration and staining with methylene blue. The methylene blue is trapped in the crack and thus helps us demonstrate it. Here we can see a patient for whom I removed a composite restoration because we suspected the existence of a crack underneath it. And I was already mentally prepared to perform a root canal treatment, but maybe even beyond the root canal treatment. And there was actually no crack when I removed the restoration and I stained it with methylene blue. I saw no crack on the tooth material. Eventually, I performed a new composite restoration and the symptoms disappeared as if they have never existed. Again, probably due to this cursed C factor, which occurs in composite restorations, especially in posterior teeth. And what does the future hold? In crack diagnosis, recent articles talk about MRI examination with the special protocol called the SWIFT for the detection of fractures and the cracks. They claim that the examination can detect fractures, cracks, and even lateral canals. But it is not yet past the research stage. So in the meantime, we will have to stick with our old and less effective methods. So we finished diagnosis and we'll move on to the treatment options. So what will we do when we diagnose a crack? This is my treatment scheme for a cracked tooth. It is very simple. It's not very complicated. We start with the mildest symptoms and progress from there. A patient complains of pain when chewing, not severe, no pain, which is spontaneous, maybe a little bit pain when he or she is drinking something cold or eating something cold, not waking them up from their sleep. Again, not severe, mild symptoms. And we decide for our own reasons that we suspect a crack, whether we saw a partial crack or didn't see a crack and suspect its existence underneath an existing restoration. So our first line of treatment is the most conservative one, which is removing the existing restoration, looking and maybe even staining, preferably under good magnification. If there is no crack, then restore and continue thinking. If there is a crack, then once in the past, we would have recommended the composite restoration using the C factor, the shrinkage during the curing of the composite to bring the two parts of the crack closer together and maybe prevent the crack from propagating, from progressing. Today, it is known that this is really not enough and there is a need for partial or even full coverage of the cusps. In other words, if a composite restoration is used, then a kind of mini onlay, but the best alternative would be a crown, which will embrace the crown and the crack together beyond the limits of the crack, preferably. and maybe even manage to prevent it from propagating into and involving the pulp, or even progressing apically and leading to extraction. Here I brought an article that followed up on diagnosed cracks without root involvement. They diagnosed 200 teeth with cracks. With the diagnosis, an orthodontic band was placed to embrace the tooth, and the patient was sent to do a full crown, a follow-up of at least 3 years thereafter, 71% without the need of endodontic intervention. 29% of teeth required a root canal treatment due to pulpitis. Teeth that were not crowned were 9 times more likely to have complications, pulp complications, and endodontic complications, significantly more than ones that were crowned. Survival rates with a crown, 81%. Survival rate without a crown, 37% after 3 years. Therefore, today, when we diagnose a tooth with a crack, the recommended treatment option will be to fully embrace the crown with a crown. If we have exhausted the most conservative option and the symptoms still persist, then we move to root canal treatment, post and core, preferably without a post and a crown. The same goes for cases where from the onset of the symptoms are those of pulpitis or apical periodontitis or even abscess. Then there is no need to go through the conservative restoration route or options, but root canal treatment should be performed in any case from the beginning when the patient arrives. And here I must also mention the option of extraction. Also, always in the diagnosis of a crack, the prognosis we give to the patient is in doubt. It's questionable. The questionable prognosis is because we cannot predict in advance the extent of the crack's progression until we open the tooth and see exactly where it reaches underneath magnification and staining. And even then, sometimes there are areas that are not clearly visible, and if the crack crosses the floor of the chamber floor, of the pulp chamber floor, or reaches and enters one of the roots, it is generally accepted that such a tooth is a tooth for extraction. I want to mention 2 articles from recent years regarding the treatment and prognosis of cracked teeth. The first article, they examined 86 teeth for the period of 11 years. And here, not all teeth received the crown. What they found was that the survival rates in the first 5 years were excellent. It was 95%, but after 11 years, they found a drastic decrease in survival rates towards 56%, mainly due to the teeth that did not have a crown. And another recent study whose important findings are in the factors that reduce the prognosis of a cracked tooth from the outset. Deep pockets, as mentioned above, 5 millimeters significantly reduce the prognosis of a cracked tooth. And multiple cracks in the tooth structure also reduced the prognosis compared with a single crack. And before we summarize an anecdotal case, but with the moral, not everything that appears cracked on the surface is actually cracked on reality. In reality, a patient who arrived immediately after she started the root canal treatment. This is the diagnostic radiograph. I told the patient's dentist not to send her because clearly this is a tooth that is cracked. We have a U-shaped lesion on the distal root, a J-shaped lesion on the mesial root, and the PDL space is widened even where it is visible. I told him, find the deep and narrow pocket or pockets and extract the tooth. You don't really have to refer this patient to me. And he said, Ronnie, I don't see, I can't find a periodontal pocket. And I opened the tooth. I don't see a crack. Please check her yourself and do the treatment. So I told him, okay, send her to me. I'll show you the crack. So I stained, and indeed there was no seen crack. And therefore I performed the root canal treatment and asked the dentist to do a crown with a temporary crown and wait a few months. Indeed, with cracks or suspected cracks, I prefer a post a core without a post, and if there must come a post, then I will prefer a fiber post than a metal post, as we again use the C factor, the shrinkage of the composite, to prevent the progression of the crack if it exists. And a few months later, this is how the tooth looks. Now, I don't know if we can learn something from this, and we saw enough cases of cracks today, or fractures, that in fact, almost all of them were eventually extracted. The only thing I learned from such a case is that even though something looks like a cracked tooth and should be extracted, sometimes it's worth opening and trying to locate the crack. And if you don't see the crack, then do a root canal treatment and follow it up. So to summarize, in 5 points that are, for me, the most important points to take from here, a bite test with a tooth sleuth is a device that is highly recommended to have in the clinic, and it helps locate and find the cracks and fractures. Probing depth of over 5 millimeters is also suspicious of the presence of a crack or a fracture. And also, if the crack already exists, it reduces the prognosis. Where is the etiology? When there are symptoms and no radiographic etiology, we must suspect a crack, and stain with methylene blue to try to visualize and see if there is a crack and how far it reaches into the tooth and roots. And last but not least, a crown, such a simple tool, but it greatly improves the prognosis of cracked teeth. And I would like to invite you to visit us in beautiful Haifa, in northern Israel. This is a photo taken from the Baha'i Gardens located inside the city of Haifa, on the northern slopes of the Carmel Mountain, facing the Mediterranean Sea. And you can actually see the Rambam Hospital. There's a tall white building on the far left of the picture. That's our facility. It's our Faculty of Medicine of the Technion, and the hospital is right adjacent to the right.
Ronnie, thank you very much for a wonderful presentation, very didactic and very clear. Let me see if there is any kind of question. If you have any question and you want to ask Ronnie something, please put it on the Q&A. Can you send the what is algorithm? Can you please send the algorithm, please?
Excuse me, to send the algorithm?
Yeah.
Of course, I'll send Jamie. I'll send you the algorithm, and
Brett, can
Sure
you?
thing.
Yeah, and I see that Brett asked it.
Gladly.
He can
gladly,
mail
course.
you directly.
Okay.
Is there any other question? You see, it was very clear. It was very good. Yeah, we have one. Oh, Michael, Tenenbaum, wonderful lecture. Very nice. If a crack on the marginal ridge has an internal, I cannot read it. It's too small. Can you see the question? Because mine is something.
Yeah, I see the question. If a crack on the marginal ridge has an indentation and can be caught by the explorer, should it be treated? Tooth appears to have no symptoms. It's a good question because it might not be a crack, or actually there's not enough information because the periapical should have some answers, because it might have no symptoms because it's already necrotic, maybe. But if let's say let's take the theoretical situation where there's only a crack which you can catch with the explorer, and the tooth is vital, then you might be safer to do to remove maybe the crack and see whether it propagates into dentin, and if it does, then maybe even do a crown.
Yeah, now fix it. Marcelo is asking, is the curing light significant?
Curing light.
Curing light
Yes.
significant for translucentation?
So you can use the curing light for transillumination. Just guard your eyes with a orange filter. Sometimes the curing light is very the opening is very big, and it catches more than only the tooth, and it disturbs. But if your curing light head is very small, then yes, it can be sufficient for transillumination.
Can we use curing finder? Red.
Yeah, you can use the caries finder easily.
Easy. Thomas Shimko from your department. Let's see what else.
I deny any contact.
Which pocket grades then if does the with pocket greater than 5 millimeter, does the root canal treatment solve this pocket?
With pockets
the pocket greater than 5 millimeter and you do root canal.
No, then we assume that the crack already propagated into the root. Then a root canal will save the infection or the inflamed pulp which is inside the canals, but the crack is still there. If the pockets are greater than 5 millimeters, then the prognosis lowers, and it's riskier to try to save and hold the tooth for years.
Yeah, it's better to take it out. Can we use cavity detector stain to detect cracks?
So yes, it was already asked before. Yeah.
After doing root canal treatment. And PT, what is PT? I don't know. Comes back a few days later. The patient is coming a few days later for crown preparation, and the crack is visible, mesodistal.
So can we do a crown? Right. So if the periodontal pockets are shallow, then I would do a temporary crown and re-examine after 3 months. If the pockets are still shallow, then you can, not safely, but most chances that they will not propagate and the cracks, and then you can do a permanent crown.
Is crown suggested for the visible cracks only on the posterior teeth?
No, for every crack.
Yeah. Let's find out the last one. how could you tell the difference between a G-shaped lesion, isolated deep pocket associated with a vertical root function versus perioendo lesion?
So a deep pocket is already a perioendo lesion. I think the question was meant to be whether it's a primary endodontic lesion or a primary periodontal lesion. So when we have a tooth that was already root canal treated, then we have to assess the quality of the root canal treatment itself. If the quality is low and we suspect even maybe a missed canal, then a deep pocket would not always be a vertical root fracture, and we might consider to do a root canal retreatment. But if we see a root canal that is perfect and there are no missed canals and there's still a deep periodontal pocket with a J-shaped lesion, then we would certainly suspect that the root canal, that the tooth is broken, the root is broken, and it's a vertical root fracture.
Okay, so Ronnie, I would like very much to thank you for your wonderful presentation. It was really an honor for us to hear you. And I would like to invite all of you on the 9th of June. We have the Amir Gazmawi lecture. It's going to be also a wonderful lecture. So hope to see you soon next month. So thank you very much for everyone and see you soon. Bye-bye.